Ede. And I'll be taking the question 5 of the National Postgraduate Exam. Can I see my screen, please?
We can see, Dr. Ede. Thank you.
Okay. So it's the first one says define medical informatics. So I'll just be talking to each of the questions on the slides. So medical informatics is an evolving field of science which deals with the acquisition, storage, retrieval, sharing, and optimal use of information in health and in biomedicine. So the second question says, what are the components of medical informatics? So the components, the medical informatics has 4 major components, and then it also has some subdivisions of this component. So the first one is bioinformatics, which is the use of medical informatics methods to facilitate research in molecular biology. Then there is clinical informatics, which is the use of medical informatics methods to aid management of patients using an interdisciplinary approach, including the clinical and information services. So providers in healthcare rely on data and technology in clinical informatics, and it's interdisciplinary, involving the physicians, nurses, the dentists, the pharmacists, and a host of others to implement a treatment plan for the patients. Then there is consumer health informatics, which is the next component, and is a field devoted to informatics from a consumer's point of view. So here, medical informatics is used to facilitate the development of electronic systems that would support public access to health and lifestyle information. Then there is public health informatics, which focuses on promotion of public health practices with research and learning using surveillance, reporting, and health promotion. So these are the offshoots of the different the components that we had mentioned earlier. So we have for biotechnology, for bioinformatics, we have the AI, we have a medical software security, we have the computerized medical records or the electronic EMR. Then for consumer, we have the telemed and etc. etc. So these are the different the offshoots. So some materials listed all these amongst the components of medical informatics, but from the update lecture that was given, this is how it was divided. So there are so many functions of medical informatics, but for the purpose of this presentation, I'll focus on this one that have been listed here. So there's improved patient care. Medical informatics provide computerized guidelines which can help clinicians and even patients to make better decisions, thereby maintaining a high quality treatment. Also, there's centralizing of information such as the medical records and patient portal, which help to personalize treatment plans for each patient and also leads to improve patient care. It also enables better collaboration and coordination amongst healthcare providers because of this centralized information. Then it also helps to develop new medical technology, design public health. So like example of this new medical technology include artificial intelligence. So it also helps to design public health strategies and digitize healthcare record systems and processes. So another function of medical informatics is improved administrative functionality. So here, understanding of what is happening in a facility can assist the key people in administration in improving quality, that's decision makers in improving quality programs. It can also reduce waiting time and create a culture of accountability amongst the managers and then the staff. And also, if less time is spent on administrative work, that means that the doctors and other health professionals can have more time with the patients, which also improves patient care. The enhanced research and public health reporting is also another function of medical informatics. So it can provide a wealth, a large wealth of data, which can be used for research and public health, public health reporting, which will help to advance understanding of diseases and also health outcomes. Then medical informatics also ensures a minimal organizational disruption by integrating electronic health records with already existing systems. So the limitations or the drawbacks of medical informatics include data quality issues. There may be inconsistency of data, which will invariably affect the reliability of the information system. So that's one of the drawbacks. Then there are also security concerns in this area of increased hacking and cyber terrorism. So there can be unauthorized user access. There can be the breaches of the data already stored. There can be hacking, fraudulent entries. So all these are limitations, security concerns that can be seen in medical informatics. Another vulnerability of medical informatics is the cost. So implementing and also maintaining a health information system can be very expensive, especially for the smaller healthcare providers. User adoption, it can be complex. The medical informatics system can be complex and also difficult to use. And this can lead to some of the old healthcare professionals, maybe who are resistant to change, kicking against the introduction of medical informatics. And so these people may prefer the traditional paper-based systems. And once there is this resistance, you see that they're not going to implement it in what they are doing. There could also be legal and regulatory issues where compliance with local laws and regulation related to health information can be challenging. And then the failure to comply may also result in penalties. Then the last drawback I want to talk about is over-dependency on technology, where staff may lose ability to function in case of any technical glitch. So what is medical, in your own words, what is a medical dilemma? So medical dilemma, in my own words, is a situation, from my own understanding, is a situation where a clinician experiences conflict between different ethical principles, leading to difficulty in determining the next course of action. So I would like to give some examples of this medical dilemma. So it's just like what we commonly see in our practice, where a patient that belongs to the Jehovah's Witness denomination comes, and maybe the patient is already very anemic and refuses blood transfusion. So you are trying to respect the patient's autonomy, and at the same time, you're also trying to do your job as a physician. Another example that comes to mind is maybe a person known to you as a clinician in your center that maybe works in the dietetics department, comes to you with a result of hepatitis A positivity, and the person doesn't want his information or her information to be divulged. So now, as a physician, you are torn between confidentiality and also confidentiality that the patient's information must not be revealed to others, and then also justice to make sure that things are done right. So that's my examples of medical dilemma. So the last question is, medical practice has gone beyond clinical work. Lists its generic competencies. So the generic competencies here are clinical governance, clinical audits, medical informatics, advocacy, policy making, conflict resolution, human resources management, and health resources management, and then teamwork. So that's the end of my presentation. Thank you very much.
Thank you very much, Dr. Eddie. It's been a very good one. It's very brief, but with full of information. Thank you very much. We entertain comments, clarification, and some additions. Thank you. Well done. It's a good one. So any other person with okay, Dr. Lawrence Ade, go ahead, please.
Thank you, Dr. Hede, for the presentation. I just need a clarification. Is there any difference between electronic medical record and this medical informatics? Any relationship between two of them? Thank you.
Okay, Dr. Eddie, over to you. Hello? Hello?
Can I be heard?
Now we can hear you now.
Okay. Thank you, sir, for the comments and the question. So, yes, there's a slight difference between electronic medical records and medical informatics. So, electronic medical records, which can also be called computerized medical records, is a component of medical informatics. Medical informatics is a broader term which deals with everything concerning acquisition, storage, data retrieval, sharing, and sharing of information in health and biomedicine. But EMR, sorry, is a branch, is a part of medical informatics.
Okay, Dr. Ade, are you satisfied?
Yes, thank you so much.
Okay, thank you, Dr. Ede. Dr. Aina, go ahead, sir. Dr. Omodele, go ahead, sir. Go ahead, Dr. Dalhat. Dr. Aina, go ahead, please.
Okay. Hello, sorry, I was muted before. Yeah, can I be heard now?
Yes, we can hear you.
Okay, yeah. Sorry, I came late and I met the presenter where she talked about medical dilemma and cited the example of somebody working the dietetics department and is hepatitis A positive. So I just want to quickly maybe just give it's not an opinion, it's the right thing to do in that kind of scenario, just in case maybe something like that crops up, so that's one. Hepatitis A, working the dietetics department is an ethical issue, and I wouldn't say it's medical dilemma really. You shouldn't cite that example as medical dilemma, and in that case, what should be done? Ideally, what should be done is, in case you are asked that kind of question, what should be done is to tell the person that being hepatitis A positive, poses, others at risk in terms of the fact that she's handling or he is handling their food, and then the mode of transmission of hepatitis A virus. So you have to let the person know how risky it is for her to continue to handle food in that setting. So what should be done ideally? You tell the person how it is, and the person has the responsibility to inform his or her head of department about this matter. So you are not divulging anybody's, because confidentiality is there. You are not divulging to our co-workers or everybody in the hospital. But the person has the responsibility, has a duty to let the, a superior, the person that posts them into different units where they handle food, to let the person know that she is now hepatitis A positive. Okay. So, of course, you arrange for follow-up to see that patient. Okay. So when you arrange for follow-up and you discover that this person hasn't told the head of his unit, okay, you can actually tell the person that you have the responsibility as a physician to let the appropriate authority know about this matter, okay? Because you don't want people to start having hepatitis A in the hospital. All the patients, some people have hepatitis B already, some people are HIV positive, and then they are now adding hepatitis A to it because somebody doesn't want to disclose his status and is infecting other people. So you can tell the person that you would tell, that person's superior about the person in charge. Just one person or two persons that can take an action about that case. So the other thing to look at is the occupational health. We have occupational health department in our hospitals. This is one of the things that they can also do when you are disabled by reason of disease, or you are contagious, or something that has to relate with your disease condition and your work. The occupational health department has, they have the wherewithal. They can step in. In fact, when you tell your superior, when the person tells his superior, the superior actually should involve the occupational health department also, and maybe if there are other relevant authority that the hospital has constituted for anything like that, okay? So they will now sit down and say, okay, you are not divulging anything to just everybody. It's just people that are involved to protect the hospital community. So they will sit down and say, okay, this person is hepatitis A positive, pending when you are expecting the person to recover from this infection, and everything you are doing to make the person recover, okay? Okay, so what should we do? Should we step her aside to another unit in the dietetics department that does not involve handling of food directly? The person will not be sacked. The person will just be allocated to another place. The person will still be receiving a salary. Everything is going on fine. Just that you need to protect, the hospital community, patients, and co-workers from, being infected with what the person has. So that is not a medical dilemma. That is an ethical issue that has to be dealt with decisively, and you have to empathize, of course, but you can't be emotional about it. You have to just take a step in that regard. So one, the person has to inform the superior. You have to involve the occupational health department, okay? And if the person does not take that step to do so by himself, informing his superior, and then, they set up, they sit down and, look at how they can handle that matter so that others will be protected. You as the physician, you can step in and inform that person's superior that this is what, because if there's an outbreak in your hospital and you are the physician and you cannot claim that you are using confidentiality, so you didn't do the needful. No, you have to step in. That's my contribution. Thank you.
Thank you very much, sir, for this contribution. Thank you.
Welcome.
Dr. Dalhatu want to say something again. Okay, go ahead, sir.
Okay. Good morning. Thank you, Dr. Ede, for the wonderful presentation. My own addition is about the definition, so that it captures a lot of things that they wanted us to mention. Yes, it deals with the retrieval, storage of information. I think usually there is some words that's supposed to be part of it, like the use of computer science and information science. So some definition, you see that they will tell you that it is an intersection of information science, computer science, and health. Then you may further try to explain this intersection of computer science, information science, bio health or health system. Then the remaining part of what you define, then it can follow that as like you are trying to expatiate further about the definition. So it could be said it's the intersection of information science, computer science, and health science that deal with resources, devices, and method required to optimize acquisition, storage, retrieval, and use of information in health and biomedicine. But it's almost the same thing. It's just to bring out the computer science so prominent in the definition. So by and large, I think also the other part of the discussion are very okay and so vital. Thank you very much.
Okay. Thank you very much, Dr. Dalhatu. Thank you for always contributing. Chief Dr. Fatima also wants to say something. Go ahead, ma.
Yeah, thank you very much, Dr. Obiamaka, for that excellent presentation. I'm happy Dr. Dalhatu brought up another definition. So I want to call your attention that it's very important to have at least two types of definition of medical informatics. We were asked this question in the exams. You know, the examiners have their own checklist. So if you give the definition that is not corresponding with the one they have, they will ask you, do you have any other definition? Give us another definition of it. So maybe they are trying to see if you have another definition that will match what they have in their checklist. So Dr. Rad, if it will be possible, please kindly send that definition you give to the platform so that Dr. Obiamaka can add it to the slides. At least having two definition is not bad, so that if you give the one that is not what they want, you present the other one. And if you are lucky, the first one you give is the one they want, then that's fine. So at least have two definitions. Then regarding medical dilemma, Dr. Aina has talked well on that. However, I used to know that it's a situation whereby you have challenge in deciding to choose an options, to choose between two acceptable or two unacceptable options. So a medical practitioner is faced with a challenge of choosing between options that both are acceptable. For instance, a situation where a patient will ask you to give him, a situation where a patient will ask you to maybe give a drug that will just seize his life, or allowing that patient to continue surviving for the fact that it's a terminal illness. For instance, a patient having a terminal illness like cancer, the patient knows he's not going to make it and he's in serious pain and requesting you to just terminate his life. So this is a situation where you maybe you are faced with a challenge of what to do. So I think this one example of medical dilemma that I once came across. So a situation where you have difficulty between choosing two acceptable or two unacceptable decisions. Yeah, so this is my little contribution. Thank you.
Thank you very much, Chief Dr. Fatima, for always there to add your contribution. Thank you. I think we continue to hear from our teachers, one or two words from them before going to the next. But in the chat, I just want to read something. I think there's only one thing from the chat that said by Ifroma Ede, your namesake. She said, good morning, please. You don't have the authority to divulge patient status or results or any patient's information. I think she just wants to clarify something. I think our teachers can come in for their contribution before we move to the next presentation. Thank you. Dr. Christabel, Chief Shitu, or Chief Cookie is around, and anybody.
Hello, Dr. Yahaya.
Good morning, ma.
Good morning. The presenter did well, and our facilitator, Dr. Aina. Dr. Aina, thank you. Dr. Aina was a class chair for 2021. He has both colleges. So thank you so much. Dr. Aina has spoken. Dr.
Thank you, sir.
Tima has spoken. Everybody mustn't speak, especially if, to keep to time. Especially if the person has done well. You don't need repeating ourselves. So thank you, the presenter. Thank you so much. I think we should move over to the next presentation.
Thank you, ma'am. Dr. Sanda, please.
Good morning, consultants, teachers, colleagues. My name is Sander, and I'll be taking the 2022 medicine recall question 6. So the question goes, list 4 principles of ethics and explain them. 2, a 69-year-old man who had a terminal cancer. His brother does not want you to tell him the diagnosis because he thinks it will worsen his condition. What ethical principles will you apply and why? And then number 3, how will you handle the situation? So the 4 principles of ethics, so we should list them. Number 1 is autonomy. Number 2 is beneficence. Number 3 is non-maleficence. And number 4 is justice. So autonomy basically is respecting a patient's autonomy as to whether or not they want to have a given form of treatment or procedure or an intervention. So if a person, an adult, a consenting adult over the age of 18 years is able to make his own decisions and is not incapacitated mentally, the person's rights to whatever happens to his body must be respected. And that is basically the principle of autonomy. And under autonomy, we have things like consent, where a person who can make rational decisions, so from as little as setting an IV line, you want to get his consent. Consent can be verbal, can be written for like surgeries and all of other complex procedures. For younger people, younger than the age of 18 years, what you get from them is an assent. So where somebody else, maybe like the father or the mother, can now give a consent on their behalf. And then for a minor who has now attained 1 or 2 responsibilities due to maybe traditional rules or a legal issue, the person can give what a consent, and you call that kind of person an emancipated minor. 2, the second one is beneficence. Beneficence basically means doing good to your patients. And in this place, you want to make sure that the patient's interests are best promoted. So you, as much as possible, want to carry out procedures that you know will be useful and beneficent to the patients. Another concept under the issue of beneficence is what they call paternalism. It's an issue where the doctor is acting like the father to the patient, and here the doctor can proceed to carry out a procedure or a treatment on the patient that he considers to be useful to the patient without seeking his consent. The third one is non-maleficent, and it means to do no harm. So in non-maleficence, basically what you want to do is that the treatment or whatever intervention you are giving to this patient will do no harm to the patient, at least in the immediate phase. And then the fourth one, justice. Justice basically means distributing medical benefits fairly. So whether the person is a Muslim, a Christian, a Yoruba, Igbo, or Hausa, for justice, you want to make sure that everybody is able to get the the largesse of the medical care fairly, irrespective of their religion, cultural, social, or gender differences, or whether they are vulnerable, as in maybe disabled or not. So the second question is a 69-year-old man who has a terminal cancer. His brother doesn't want you to tell him the diagnosis because he thinks it will worsen his condition. What ethical principles will you apply and why? So in this case scenario, the ethical principle I will be applying will be autonomy. First of all, is the 69-year-old man able to make his own decisions as to what he wants done for him? And if he's able to give consent, and like I read somewhere, consent is not just a one-off thing that you assess one-off during a patient's care. It's something that you assess and reassess whether or not the patient is conscious enough to give that decision at that particular time. And there are different modalities to check if the patient can make a rational decision. So if the patient at the time can make his own rational decision, the patient's autonomy should be respected. The diagnosis should be told to him, and he should be part of his medical care. His decision is needed at this point. But in a case where the patient is incapacitated, then you want to check who has the lasting power of attorney. And the person with the lasting power of attorney doesn't necessarily have to be a relative. So which is the reason why sometimes it needs to be probed. So whoever has the lasting power of attorney is the person who you want to carry along directly in the patient's care. The third question is, how will you handle this situation? So this situation will basically be handled through dialogue. First of all, the brother who is the one advocating for this situation not to be shared needs to be educated as to why this patient needs to be carried along in his medical care if the patient can give consent. And if the patient cannot give consent, I want to know the who has the lasting power of attorney. If it is this brother or somebody else, and that person will need to be carried along in this particular situation. So as to first of all is to so that the patient can feel like a part of his care was, a part of his decision was taken in handling his medical care. And two, if the patient also gets to know about this, the patient has a right to pursue a legal cause that his own medical care was not, he was not carried along in his own medical care, whether or not the doctor thought he or she was doing right by the patient. And this case scenario is almost similar to what was just previously discussed by the other speaker. So I would have to explain my role to the doctor and to the relative as a physician and inform him of the patient's rights, while the patient needs to be carried along in his decision making. The patient can give consent especially, and then also give him examples as to why the patient has to be involved in his care. So I'll just quickly rush through this. So the principle of ethics. Ethics is a major branch of philosophy that encompasses right conduct and good living. It's significantly broader than the common conception of analyzing right and wrong and various ways of understanding and examining the moral life. These are according to Beauchamp and Childress. The study of morality, careful and systematic reflection on analysis of moral decision and behavior used by the World Medical Association. Now, bioethics is the ethics of biological science and medicine, and means by which men decide between right and wrong. Over time has been debated. Some people say, is it conscience, situation, law? Is it by God or religious beliefs, political leaders, ethical guidelines, and superior decision? The importance of ethics is the reflection of respect for those who take part in research and also clinical care. It ensures no unreasonable, unsafe, or thoughtless demands are made by researchers, and it ensures sufficient knowledge is shared by all concerned. It also imposes a common standard. Now, there have been a number of history to like examples to cite different areas where ethics were not really followed. So I just listed a few. So public attention was drawn to questions by abuse of human subjects in biomedical experiments, especially during the Second World War. We have the Nuremberg war crime trials, where the Nuremberg Code was drafted as a set of standards for judging physicians and scientists who had conducted experiments on people in concentration camps. You have experiments on Jews, gypsies, and political prisoners by Nazi doctors. So these are specific examples. The 1932 Tuskegee syphilis study, the 1958 thalidomide study, the 1963 to 66 Willowbrook study, and in the 1996 Pfizer's Trovan clinical trial in Kano. So these are basically the principles of ethics that have been mentioned: respect for autonomy, beneficence, non-maleficence, and justice. And like we said, some of them have some sub branches, like beneficence. I explained the concept of paternalism. Under non-maleficence, we have the concept of principle of double effect, which is when a procedure or treatment or intervention offers immediate benefits, which is certain, but may cause harm later. And example is when you give a narcotic analgesic to a terminally ill patient. So the patient will definitely get relief of the pain, but it may later depress the respiration of that patient. Under autonomy, I explained the consent, the principle of contest, assent, and emancipated consent. Also, there's the principle of assumed consent, which entails the doctor carrying out an intervention or giving treatment that he or she assumes that the patient would have given consent for if he or she were incapable. So that's another concept under the area of autonomy. There's also confidentiality, which is patient information must not be divulged to others, even after his or her death. And in an event that the patient becomes incapable of decision making, the doctor must make effort to determine the legal proxy of the patient to receive this information. So respect for autonomy involves acknowledgement of autonomy of the client, cultural sensitivity, ensure highest level of privacy is provided, human dignity, and veracity. In practice, respect for autonomy of persons can be achieved through consent, verbal/written, confidentiality, and protecting privacy. So when you're checking for respect for autonomy, you ask yourself, does my action impinge on an individual's personal autonomy? Do all relevant parties consent to my action? And do I acknowledge and respect that others may choose differently? For beneficiaries, who benefits from my action and in what way? How do I maximize the benefits? It must be scientifically robust. You must prioritize your participants' welfare with a research, maximize their benefits, and how you act on the results. Just mention all of this. For non-maleficent, which parties may be harmed by my action? How do you want to minimize this harm? Have you communicated the risk involved in a truthful and open manner? And in event of a disaster, how do you want to avert such harm? For justice, have you identified all vulnerable groups that may be affected? How do you ensure distribution of burden and benefits? Is the proposed action equitable, and how can you make it all equitable? By allocation of risk, allocation of benefits, and allocation of resources. So justice also ensures protection of vulnerable patients through practice, equitable distribution of delivery care, and we've said equity is achieved through allocation of risk, benefits, and resources. These are my references. Thank you very much.
Thank you very much, Dr. Sanda, for this wonderful presentation. Thank you. The floor was good and slight, but okay. Thank you very much. We entertain some other additions. Thank you. Okay, Dr. Dalatu, go ahead.
Okay. Thank you very much for the wonderful presentation. I really learned a lot from your presentation. So I just wanted to draw our attention to the second part of the question, that they mentioned the patient, and the question said, what ethical principles will you apply and why? So I think the examiner wanted us to talk as many possible principles as possible, because in most of the situations like this, consider you can apply more than one principle. So you choose to apply the autonomy, which is a very good one. So I think also we can, after mentioning autonomy, I may decide to use the beneficence as also another principle to utilize in counseling my patient, and telling him that the principle of benefits emphasizes the obligation, and then for the interest of the patient also and his overall well-being. And then also I will try to let the brother know that disclosing the terminal illness, like the cancer diagnosis of the patient, may align with the principle of beneficence by enabling him to receive appropriate emotional and psychological support and engage in meaningful discussion with this patient, so that we don't keep the patient unaware. So by telling him, yes, it's actually a terminal illness, but there are things that we can do. We can alleviate your pains. If you don't have blood, we are going to add blood to you. We make sure that if you are not unable to swallow, we bypass by giving gastrojejunostomy and stuff like that. So I try to encourage him about the benefit of what we are going to do to him. And also I may try to apply justice, because he is a human being and we have to be just in what we are doing, and that will let him and his brothers and sisters and all other caregivers to take an informed decision as far how far can they go with this illness. Are they going to push hard, or they are going to go small, where they may not expend most of their resources? So I think we can try and create as many principles as possible while discussing this question, especially with the question come in plural. And then my other small contribution is about the consent. You should remember that there are two types of consent, either opt-in consent, opt-in and opt-out consent. Like the common one used is that of HIV testing, where we can have opt-in method and opt-out method. In opt-in method is you are going to, like I said, example for HIV testing, that either you do the counseling, pre-test counseling in group or as an individual, you tell the person the benefit of having HIV testing, and these are the benefit, these are the possible outcome for the testing, and I would like to do the testing for you guys. Can you bring your hand so that we take blood sample? If the person brings out his hand for you to take blood sample, it is as in that he has he consents for that procedure. That's the opt-in method. Then for the opt-out method, you discuss with the patient, but we want the person explicitly to say, I want to get the test. Do you want to get the test or you don't want? Then that's another thing that we use, especially for HIV testing. So we should remember this one. Thank you very much. By Allah, it's a very good presentation, and I learned a lot from your presentation. Thank you.
Thank you very much.
Okay, thank you very much, Dr. Alhat, for always being there to add one or two things. Dr. Olaitan Abimbola also want to say something. Go ahead, please.
Okay, good morning all. Thank you for the beautiful presentation. I just want to add that under beneficence is the reason why we need to tell the patient that he needs to understand his condition in case there are some steps he needs to take about his life, some things he wants to achieve or do, or put some things in place, writing a will, setting some things in order for himself and his family as well. I think it should also be added to the reason why the patient needs to know. Thank you.
Thank you very much for the contribution. I think we can, let me read out the charts before another contribution. Chief Dr. Omodele Aina said, this is not correct in all instances. You can, in specific circumstances, if this patient is not okay, that one is for the last one. He said, Dr. Ekele said, good morning, everyone. Thanks so much for the beautiful presentation. Please, you mentioned something paternal when you were talking of beneficence. Please throw more light on how to assess the patient's competence to make his own decision. That was what Dr. Ekele said. Then Chief Omodele Aina said, and another example is you are a cardiologist seeing this. Okay, that one is still okay. Let me just read out, sir. You are a cardiologist seeing this patient, this hepatitis A patient. He's also seeing the general practitioner or any other specialist for any other general health issues. So he tells you not to communicate via case notes, referral letter, etc. to his GP or any other specialist he's seeing. You cannot use confidentiality in that case. You have to tell the patient respectfully that it is his own interest to let his other doctors know his status so that they can put it in a view when administering care to him. And you have to communicate this professionally via the case notes, referral, etc. With his other doctors. So those are the things in the chart, please. I suggest if maybe Chief Aina will clarify more on what he is preaching. Thank you.
Hello?
Yes, sir. Go ahead, sir.
Okay. Yeah, well, I actually just have maybe a contribution more in form of a question for the last presenter.
Yes, sir.
Okay, yeah.
Yes, sir.
So let's say this terminally ill patient with cancer maybe now becomes unconscious, and this his uncle comes again and says, well, that this is what he wants you to do for him, or this is what the family wants you to do for him, being unconscious and terminally ill. You know that maybe he will likely not recover from the illness, or maybe he will recover, but in that instance that the patient cannot make decision by himself. Okay, he can't make decision by himself. He's unconscious. So the uncle now comes and says, this is what he wants you to do, or this is what the family has agreed for you to do. And in that case, what would you do? The question is to the
Thank you very
presenter.
much. Yes, thank you very much. I want to just be clear. The question is that the patient now lacks capacity or has gone unconscious. I can't make decision of himself.
Yes.
And this same uncle has come back. So in that case, you would want to find out who has the lasting power of attorney, which is what is applied in most countries where people cannot give consent for themselves. And the lasting power of attorney might not necessarily be the relative. It might not be wife, husband, son, daughter, father, mother of that particular patient, you know. And the person who has that lasting power of attorney privilege is the person who you would want to make decisions on that patient. And the only time in which you will not want to oblige that person is when you feel as a clinician the person is not acting in the best interest of the patient. And in that case, you want to step up and go to the court of protection, you know, and take your decision at that level. And in situations where there is no actual lasting power of attorney in terms of a document, you as a clinician want to use what you call your best medical practice and take what decisions you think will be in the best interest of your patients. I think those were the things I was able to get to as possible answers to this question, but I will entertain other contributions. Thank you very much.
Yeah, excellent. You are very correct. In that instance, you take the decision. If there's no lasting power of attorney, you have to step in and take the decision for the patient. And you know, lasting power of attorney, you know, is not only for health. You know, there's lasting power of attorney concerning finances and also concerning health. So because it's also possible they come and say, okay, because of some money in the banks and in the bank and different things. So it doesn't really only it's not limited to health alone. It's both usually it's for health and finance. So you have to know which one the person stands in. But you're absolutely correct. In the setting that the patient lacks capacity, there's no lasting power of attorney. You as the doctor or the medical team would have to step in and you act in the best interest of the patient. It might be that you won't even intervene at all, that you have judged this patient that this patient would not recover from this illness. So there's no point trying to do any life-saving intervention for this patient. So in case it goes into arrest and all that, you make your decision. If the family comes and say, this is our decision, your own decision as a doctor, where it is not only just one doctor in this instance, it will be like a team. Your decision as a team overrides the decision of the family or any other person that comes and say they have a say in the case when they don't have the lasting power of attorney for health concerning that patient. Yeah, so absolutely correct. Well done.
Thank you, sir, for this wonderful contribution. Thank you. We appreciate your presence, sir. Thank you very much. I think it's high time for our teachers to come in. Dr. Olaitan, is it the hand you raised before or is a new raising hand?
Oh, sorry. Previous hand. I will remove it.
Okay. Maybe it's a time for our teachers to come in. Chief, Dr. Christabel, and other teachers can please shed more light. Thank you.
Dr. Aina is a teacher.
Yes, ma'am.
And he has come in already.
Yes, ma'am. We appreciate that one.
Okay. The presenter really, it was a wonderful discussion and so far discussion will be quite interesting and really clear. I must appreciate from my end there's really nothing because the presenter did a good job. Dr. Aina came in, Dr. Dahatu, they also came in. So no need of flogging issues just because you want to speak. So I must appreciate them for their contributions. I don't know if anyone has any other thing to say before we close the class.
Ma, there is a chat. Let me quickly read the chat. Dr. Shamsuddin said, thank you for the presentation. The question on how to assess a patient's capacity and competency to make decisions has not been addressed.
Yes, sorry for not addressing that. Basically, I'm just going to be giving this a try. I didn't really find any text as to how to assess competency or capacity, but I'm assuming that based on clinical judgment, so you want to, first of all, is this patient conscious? And if the patient is conscious, you want to know if this patient is oriented in time, place, and person. If this patient is oriented in time, place, and person, you might want to do maybe a mini mental state exam for these patients. And after you have done all of this, you now want to educate the patients about the procedure or intervention or the case that they want to take, at least what you think a reasonable person should understand based on the patient's level of occupation. And if you feel the patient has so far been rational and can, give you a feedback as to what they have learned and gives a reasonable insight into the condition that they have, then that patient should be judged to have capacity and can give consent in regards to his treatment. That's what I would answer if I was faced in the exam. Thank you.
Thank you very much.
So that's fine. I think the presenter did a good job. Thank you so much. Showed you.
Hello. Hello.
Oh, yeah.
Yes.
Hello. This is Dr. Aina.
Okay.
So I know. Okay.
Yeah. Can I quickly come in to answer that question?
Okay, go ahead, please. That's why you're in class.
Okay. So to assess for capacity, I mean, we don't have these laws, but these laws are really, really very prominent abroad. So it's not by mini mental state and all that. Yeah, maybe if you are asked in an exam, maybe like it's a 10-minute encounter, and that's the only question they ask. You can talk back and forth, because you don't have to stop. You have to just continue talking and all that and explain yourself. But essentially, assessing capacity is in 4 dimensions. There are 4 things that you need to, the 4 things to note to say patient has mental capacity. Number 1 is the ability to understand, the situation, or like to understand the information that is related to a decision. Okay, so the patient has taken a decision on his own care. Okay, but you are thinking that this decision that this patient has taken, it sounds illogical, it sounds unreasonable. So you want to know, does the patient understand this information, the information about his health, about, and does he understand this decision he's making? 1. Then 2, you want to assess, you want to, see whether the patient has ability to retain that information. Then 3, you want to know whether the patient can weigh the information, okay, can weigh the pros and cons of the information, okay, as part of the decision-making process. Then you want to know if the patient can communicate that decision, So number 1, ability to understand the decision. 2, retention. 3, to weigh up the decision. And 4, to communicate. So yes, like you said, it has to be during the patient-doctor interaction. So if you have asked the patient has made a decision, and you ask the patient, okay, you have told the patient what the thing is about and everything, then the patient has made a decision. So as you are talking to him, you want to know, does he understand what he's saying? For example, okay, can you tell me, recap, what do you know about this condition? What I've told you, can you just tell me back? Do you understand? Do you know if you take this decision this way, do you know the consequence? If you do it this way, do you know the consequence? So as you are interacting, you know whether the patient understands what you have said. Patient that you have told a number of things, he wants to tell you back and he's telling you gibberish, or he's just, it's not on point. Now, this patient doesn't actually understand this thing. Can he retain? Of course, again, retrieval of information. Okay, that's why sometimes in ethics, they will say when you are discussing with the patient, you are maybe explaining a diagnosis to a patient or a procedure or anything. It's always better to say, okay, can you recap some of the things I've told you? That to recap is not that you are just doing it for fun. You want to know whether the patient can retain what you have said, because the decision would come from the ability to understand and to retain. And then to weigh the pros and cons. Okay, so the patient knows, for example, that somebody is smoking and he has cancer, stop smoking, and he says, well, no, I don't want to stop smoking. I'm just, that's hypothetical. But does the patient know that if he doesn't quit smoking or he has COPD, he doesn't quit smoking, this disease is going to take his life, going to deteriorate, it's going to take his life, he's going to have to need oxygen, home oxygen, or it would even exclude him from being administered home oxygen therapy. You know, that all those things. So to weigh the pros and cons, you have to find out that. So that's a third leg of assessing for mental capacity. And then the other one is to the ability to communicate this decision, okay? To be able to communicate it, to others. So those are the 4 things I want to know. 1, understand. 2, retention. 3, ability to weigh up the decision, and then 4, to communicate the decision. That's what mental capacity entails. Thank you.
Thank you very much, Chief.
Thank you, Dr. Aina. Thank you. Was there. See why I said we're coming to class. So please keep it up. Thank you.
Okay, thank you.
I appreciate your presence. So Dr. Aina was our, I think, 2023 class rep for national. So thank you so much. We appreciate you. I don't know if there are any more comments from any of our teachers. In the absence of any more comments, let's close the class. I think I started Dr. Success. Dr. Success is now a facilitator. Welcome to class. I don't know if I saw others. I didn't see anymore. I think I saw Paul. So thank you guys for coming to class. Please keep coming. We appreciate your presence. All that facilitators, Dr. Aina, Dr. Fatima, Dr. Kopi, Chief Manza, Chief Kuke, so I think I don't know if I started another person, but thank you all. We appreciate your presence. Dr. Yahya, please help me stop the recording.
Okay, ma.
Dr. Kunuga, thank you. Thank you for coming to class.